Welcome to Trojan Talks. I'm Byung-Soo Kim, president of the University of Southern California. And this podcast is a space for open conversation with thought leaders both inside and beyond our university as we explore the ideas shaping USC's future. Today, I am delighted to be sitting down with Professor Eileen Crimmins, professor at the USC Leonard Davis School of Gerontology and a leading scholar in aging, demography, and population health. Eileen, thank you so much for being here with us.
It's a delightful day to be here.
So I wanted to talk first about the field of demography, population health, aging has changed so much in the decades since you've been working on these issues. I want to kind of start most recently and ask you what you're working on right now.
The real topic of central focus right now, I would say, is where can we find the sort of triggers of aging and how can we intervene? Now, I think one of the major changes is that what we have decided is that sort of a set of molecular and cellular changes underlie all the diseases and health outcomes that occur more at older ages. So it's not you're going to have risk for cancer, you're going to have risk for heart disease. You're going to have a set of molecular and cellular changes that may in the end result in a heart disease, but it's the same things that are underlying cognitive change, physical change, and disease onset. So we're trying to identify those things. And those are things people didn't even know about when I came here. It's a level of study that was not possible, was not done. So these molecular and cellular changes right now are called the hallmarks of aging, biological hallmarks of aging. And they include genomics, changes in senescent cellular composition, changes in the length of telomeres. These are all things that are ongoing at all times for all people. We think that many of these things start very early in life. Some of the fastest change in some of them may actually be in the first couple years of life. After that, the change continues, but it may be slower. We're trying to identify these actual molecular and cellular changes in human populations. And that's another thing for much of my career. Biology here and what was supported by the National Institutes of Health was work in non-human species. There's a much greater focus now on humans and on translating these things into human populations to study. So we have, the social scientists, we have been collecting data on humans now for more than 30, 40 years. We have lots of samples in freezers that we're now taking out, and we're able to measure many of these things that weren't even identified when the samples were collected. So that's one of the benefits of being around for a while and having old data sets that actually the people have aged, and you can actually trace some of that now.
You hear people increasingly talking about and differentiating between biological and chronological age, and of the research that you've done has helped to support that distinction. There's also been, over the last several years, a lot of interest in biohacking and trying to reverse the biological cellular aging process.
Yes.
And I guess I just wanted to ask you for your reactions to the intense interest that we're seeing in that area.
So let me say, first of all, there is a large and identifiable difference now between biological age and chronological age, which is measured simply as the number of months or years since you were born. And the biological age indicates that there are some people that are aging fast and some people that are aging slow. So when we look at 70-year-olds, we see some that look biologically like 80 or 90-year-olds, and we see some that look like 40 or 50-year-olds. So we're trying to get at that in a large representative set of people to see who are the people who are young and who are the people who are old. Now, when you're trying to identify these mechanisms, this is what you're talking about in terms of the biohacking. What's going on in Silicon Valley is people are going after one aspect of molecular or cellular change or another, and many people are starting to use substances to change their aging profile that are not yet shown to be positively related to delaying aging.
And because none of these are controlled experiments, it's not as if they have any kind of research value.
And one of the problems is just it's very hard to get measurement of these things that's consistent and stable over time. I mean, we had a recent meeting where we showed one of these measures, epigenetic age, that's used a lot for people. If you take a single person and you measure that person every single day for 3 or 4 months, you can get a range of 8 to 10 years. Well, any single measure or 2 measures it's not going to be reliable. Mm-hmm. So a lot of this is not yet valid and reliable for use on individuals. Sometimes even when it's well measured at a population level, it's still not right for individuals. So there's a long ways to go.
And out of curiosity, is there developing a kind of leading way of measuring biological age,
yes,
whether it's the epigenetic measure or some other?
Yes. I mean, I think what we've learned over 20 or 30 years is we started measuring biological age using a set of measures that related to multiple physiological systems across your body. So we'd have a measure for kidneys, a measure for liver, a cardiovascular, a metabolic, lung. We might do 12 systems and get a set of measures, and we put them together and we make a biological age. That was sort of how we did it before about 2013, when Steve Horvath, who was actually from UCLA, introduced an idea of epigenetic age. Now we have many epigenetic markers. We have proteomics. We have metabolomics. We have a large series of these things. And we can make biological ages across them, and we can compare them, and they're related. They're strongly related, from if I have an epigenetic age and then I have a biological age that might be based on, say, 12 clinical measures that you would regularly get from your doctor, I can get a correlation of about 0.65 or 0.7. It's quite high. So they're related, which means it's a pathway. If you want to intervene, you may want to intervene way back in the beginning, and we think the epigenetic changes precede the clinical changes that we eventually observe in people, and then that precedes the disease onset that we see in people. So we're talking, I think, in the long run about intervening in aging among people who are in their 20s and 30s and starting to change things for people at those kinds of ages. And we're starting to see that there are certain social factors that have very strong effects. It's not just genetic by any means. Social factors are very strongly influencing these kinds of molecular and cellular measures. And you can change the social life, and you can change much of the biology. You can't change the basic genetics yet, but there are big things coming on the horizon, but they're not here yet.
One of the most interesting findings of your research, though, has been the extent to which some of these aging processes may occur in childhood. And
yes.
I was wondering if you could share a little bit about what your research has found.
We've come at this from a variety of ways. We can use reports of hardships in childhood and early life which we routinely get in these large population studies, we can relate those to some of these epigenetic markers. We've related them to biological age. We've related them to epigenetic age. We have not really been able to follow populations all the way from birth to, old age yet, but we see young people in their 20s, 30s, 40s. We're seeing changes that are in response to social situations in what we would call biological age and epigenetic age. I think what we're not sure of is, what the changes between birth and age 10 and maybe 10 to 20, but we're pretty sure that by 20, there are quite substantial differences in the population. If you are poor, if you are do not have a supportive family, if you do not have health care, if you are a minority member, you are going to already look worse on these biological age measures by the time you're in your late 20s or 30s. So we know it's happening early. We have always taught in the School of Gerontology that aging begins not at birth, but before birth in your grandmother's ovaries. And so things that happen extremely early in life and maybe even to the generation before can actually have long-term effects for you. Now, when I first came to USC, I said that I was interested in mortality change in this amazing increase in life expectancy among older people, which began in the United States, really relative to other countries, but then happened in all of Europe and many other countries. I worked with a biologist here, Caleb Finch, who just retired last year, and he and I looked at a lot of data from a lot of countries, and what we really decided was that a lot of what the current decline in mortality among old people was resulting from was from their early life changes when they were children. That what happened over time is that these cohorts gradually had less and less exposure to infectious disease, and their bodies essentially grew stronger and better. And and also probably their brains and minds. And as they got to old age, they were better equipped for the then aging process. So they had stronger bodies. And we've produced a lot of evidence that basically this happened across the world. And, looking at the timing of various countries, you could sort of identify that it was early life changes that actually probably made whole cohorts get healthier. And that was a hard thing to pick up studying individuals over time, but studying whole cohorts, you could see it.
And one of the other really interesting things that I understand you found is also the differences between countries in terms of how you age, when you age. We think and are concerned in the United States about the lack of progress we've made recently with respect to lifespans. Yeah. And your research suggests the picture is a little bit more complicated.
There's a clear issue in the United States right now that we are way behind where we should be in life expectancy overall. We now rank somewhere in the 60s, depending on what data set you use, in life expectancy, 60s. That means that the countries ahead of us are not people we ever thought would be in the same ballpark we're in. The leaders are traditional in some ways. Japan always has been for many years a leader. But now Hong Kong and Singapore and South Korea has shot to the top in terms of life expectancy very, very quickly and exceeds ours by 5 years. I mean, this is ridiculous. This is really a disaster in the United States. We peaked in life expectancy at 2014. So we've gone a decade with no improvement. We have very poor showing at many ages. We do pretty well at old age. We are among the leaders in the world at old age. Once you get old, maybe it's a coincidence that we have almost universal health care at old age and we don't have it at young ages, but maybe it's not a coincidence. We do well at old ages. We do well when we know there's a problem, we know what to do with it, and people get access to tackle it. But we have a lot of people who don't have health care. We have a lot of poor behavior. We are more obese than most of the world. We have a lot of problems. So I believe we should make America healthy again. How to do it is a question, but there are issues about sort of trading off life for health. And I think early, when the improvement in life expectancy was happening, we thought, oh, okay, health is obviously improving because you die because, you're not healthy. But we sort of worked at it, and all of a sudden we realized, well, the population really isn't getting healthier. And that basically happened because what we were doing was what we wanted to do. We were treating people who had diseases. We were saving them from dying, but we didn't save people from getting diseases in the beginning. We were saving them once they already had diseases. So the prevalence of disease went up markedly in the United States and other countries too, but markedly in the United States. And also the number of diseases any individual has. If you live long enough, you're likely to get more diseases. So we actually ended up with a system that we'd improved what we set out to improve, which was mortality, by saving people with medical interventions. But we ended up with a population that wasn't necessarily healthier. So that's the complexity of the policies that you need to deal with all these things and the expectations you need to have when you actually intervene in populations. Sometimes you get unexpected consequences. Not always good.
So even if we're better than other countries at extending life through medical interventions, once they reach a certain age,
right,
we're not necessarily extending their health spans.
We have not been, no, because we have not necessarily been extending their health spans. We have been lengthening the life with disease, maybe not as severe as it would have been, but with disease. So, and we've been increasing the number of diseases they have. So to improve health span, clearly, you have to prevent the disease from ever occurring. And that's what we're aiming at with saying where we have to intervene is before the biological risk increases, before the molecular and cellular changes get worse. We have to intervene then, so we push off the onset of the disease to later ages. And maybe the best place to intervene would be in children. Maybe we would get the most bang for our buck if we made sure every child in this country lived to be as healthy as he or she could up to adulthood.
Yeah. Are some of the countries that you cited that have longer lifespans and have been extending those lifespans, Japan and some of the other countries you mentioned, also countries that are doing it by extending health spans?
Not really. We're pretty much all in the same trade-off of health span and lifespan boat. They have mostly countries extend lifespan and sort of health span follows behind, keeping essentially a difference that's about the same. So we're not necessarily better or worse at that part of the equations.
One of the factors that I don't think we've talked a lot about is behavioral health.
Yes.
And I was wondering if you could share a little bit about what role that could actually play in aging in some of the research you've done.
For a while we thought that the poor performance of the United States in terms of life expectancy relative to other countries came from our smoking patterns. We were early smokers, and we got very high levels of smoking in the United States. And we thought, then we were early to drop back from smoking because we changed policies relatively quickly and focus on smoking. So we thought we would, improve relative to the other countries because, in fact, other countries are worse in terms of smoking than we are now, many European ones. One of the interesting things is if you get some countries, men and women don't behave the same. For instance, men smoke, women don't. A lot of the Asian countries are much more that way. But in Europe, the more equal women get to men, the more they behave like men and they smoke like men, which means then they get health that's worse like men. So there are these sort of complex things. Now the Europeans are perhaps being held back a little bit by their, relative to what's happening here, held back by their smoking. Okay, that's one behavior. We have had a large problem of drug usage and drug deaths to the middle-aged population. That did not exist in countries that are similar to us in income. In Europe, for instance, our availability of drugs and perhaps our use of prescription drugs was much more prominent and pushed drugs much more throughout the population, so that the illegal drug usage here that resulted in a lot of that deaths did not happen in other countries. So the weight gain that we have experienced over the last few decades, we sometimes are sort of competing with Mexico to be number one in obesity in the world. We're much heavier than other places. Why? Because maybe we eat worse, maybe we drive more. Why do we drive more? Well, maybe we're richer. Maybe we have houses that are further apart because we have a bigger country. There are all kinds of complexities to this. But health behaviors matter. And we've not been very good at maintaining physical activity among people while at the same time not eating too much. Yeah. So we've increased our food consumption and our calorie consumption, and we've decreased our physical activity. It doesn't go together well.
It's just amazing how the field is just kind of drawing so many different sources of information and data and using it to really advance our understanding of this complex area. Do you have any message for students or others who are thinking about doing research in this area?
Well, there's a lot of research ongoing in this area. I think the interesting thing to do is to say, what are the problems in society that this research can address? Clearly, the current health status of the population is one. The current ability to change health is another. The availability of health insurance and the meaning of that is another. There are so many problems that are related to this that we can address. And there are so many places at USC where these things are being addressed. We are one of the largest, and I receive one of the largest amounts of NIH support for social science, research, and aging in the country. And, it's the Davis School, it's the Caesar Center, it's Dornsife, it's the medical school, it's across campus. There are many people doing this kind of work. And it's a good place where you can find a multidisciplinary set of investigators to address questions that are really complex and require input from lots of different disciplines.
Well, Professor Crimmins, thanks so much for your leadership in this field and for your leadership at USC. Thanks you very much for your time.
Thank you.
All right.